All right, today we're tackling one of the most elegant and, let's be honest, sometimes confusing symphonies in all of human physiology, the menstrual cycle.
So, have you ever felt totally lost trying to track which hormone does what and when? Yeah, you're definitely not alone. But trust me, if we think about it like an orchestra, with a conductor, signals, and performers, it's all going to start to click. So let's dive right in.
Okay, so here's our game plan. We're going to start with the conductor, up in the brain, listen for its signal, then see how the pituitary and ovaries play their parts. And finally, we'll tie this whole symphony together and see what it means when you're with a patient.
All right, first up, the master conductor. We're talking about the hypothalamus. This is the spot where the entire cycle gets started, setting the tempo for everything else.
So, take a look here. This is the anatomical control center. See that little area, the arcuate nucleus of the hypothalamus? That's where it all begins. Now, it doesn't just release its signal into the general bloodstream, no way. It uses this special private route called the hypothalamo-pituitary portal system. Think of it like a dedicated hotline, right? It makes sure the message gets straight to the pituitary gland, loud and clear without getting diluted.
Okay, so how exactly does the brain talk to the endocrine system? It's through this really cool idea called the neuroendocrine transducer concept. Basically, the hypothalamus is a translator. It takes electrical nerve signals, which, by the way, can be influenced by things like stress or emotions, and it translates them into a chemical hormonal signal. And that is why a person's environment and emotional state can have a very real impact on their menstrual cycle.
Next, let's look at the conductor's baton itself. This is gonadotrophin-releasing hormone, or GnRH for short. It's the key signal the hypothalamus sends down to the pituitary.
GnRH is actually pretty simple. It's just a decapeptide, only 10 amino acids long. But what's really fascinating is its half-life. It's super short, only 2 to 4 minutes. So what does that mean? It means its effect is gone in a flash. And that makes it completely dependent on how it's released, which brings us to our next point, and honestly, it's the most important one.
Okay, if you remember one thing from this whole explainer, let it be this. GnRH function is all about the pulse. It is not a continuous stream. It's released in these rhythmic bursts. This pulsatility, it's everything. It's the secret language spoken between the hypothalamus and the pituitary. And here's why that's so critical. When GnRH comes in pulses, it keeps the pituitary receptors listening. They stay sensitive and responsive. We call that upregulation, and that's the normal way things work to promote fertility. But what if you give GnRH continuously, like with certain medications? You'd think it would rev up the system, but it does the exact opposite. It paradoxically shuts the whole thing down. The pituitary receptors just get overwhelmed and tune out. That's called downregulation. And this is a super powerful clinical tool we use to treat things like endometriosis or fibroids.
So what stops this pulse generator from just going wild? Well, it's all managed by feedback loops. Just think of it like a thermostat system working on 3 different levels. First, you've got the ultra-short loop, where GnRH basically tells itself to calm down. Then there's a short loop, where the pituitary hormones, FSH and LH, talk back to the hypothalamus. But the main control, the big one, is the long loop. That's where the hormones from the ovary, estrogen and progesterone, send a message all the way back up to both the brain and the pituitary to keep the whole axis in check.
Okay, so the conductor has waved its baton. Now let's see how the orchestra responds. That GnRH signal reaches the gonadotroph cells in the anterior pituitary. These are our first violins. They get the cue, and they start to play their 2-part harmony.
And those 2 parts are the gonadotropins. First, we have follicle-stimulating hormone, or FSH. Its name tells you exactly what it does. It stimulates a group of ovarian follicles to start growing. Then you have luteinizing hormone, or LH. Think of LH as the trigger. It's the one responsible for the final maturation of the egg and, its most famous job, for actually triggering ovulation.
So, how does the pituitary know which one to release, FSH or LH? Well, it all comes back to that pulse. The gonadotroph cells are smart. They don't just hear the signal, they interpret its frequency. Slower pulses, that favors FSH release, like we see in the early part of the cycle. Faster pulses, that favors LH. It's incredible, right? The conductor just changes the tempo to completely change the music.
And now, it's time for the main event. All these signals from upstairs lead to the actual performance, the cyclical changes happening down in the ovaries and the uterus.
Okay, let's walk through this classic graph together, because it tells the whole story. In the first half, the follicular phase,
FSH is doing its job, stimulating follicles, and those follicles are pumping out estrogen. Now, as estrogen rises, it at first has a negative feedback effect. It tells the brain to cool it. But here it is, the single most important plot twist in the entire cycle. Once estrogen hits a really high peak and stays there for a couple of days, it flips the switch. It goes from negative feedback to positive feedback. Instead of holding back the pituitary, it now yells go. This causes that massive dramatic LH surge. And that is what triggers ovulation. After ovulation, what's left behind becomes the corpus luteum, and it starts producing progesterone, which defines the second half, the luteal phase. If there's no pregnancy, the corpus luteum fades away, hormone levels crash, and menstruation begins.
So while all that is happening in the ovary, the uterus, our concert hall, is getting ready too. This table breaks it down nicely. In that first phase, estrogen from the follicles is in charge, and it causes the uterine lining to build up and thicken. We call that the proliferative phase. Then, after ovulation, progesterone takes over. Its job is to make that lining secretory, which just means it becomes rich with nutrients and blood vessels, ready for an embryo to implant. And if that doesn't happen, the hormone support gets pulled, the lining sheds, and the cycle starts all over again with menstruation.
Okay, so you've got the physiology down, but how does this all translate to a real patient sitting in front of you? Let's quickly bridge that gap from theory to the clinic.
A good history is absolutely essential. You've got to ask about menarche, the age of their first period. You need to know about regularity and length of the cycle. How long does the bleeding last? How heavy is it? And of course, the one you always ask, the first day of the last menstrual period, the LMP. Just asking these few questions gives you an amazing window into how that whole HPO axis is functioning.
Then, after the history, you move on to the physical exam. And a really key part of this is the bimanual exam. This is where you can actually physically assess the end organs we've been talking about. You're feeling for the uterus, its size, its position, and you're checking for any issues with the ovaries, like enlargement or tenderness. A simple exam like this can give you huge clues about any structural problems that might be messing with the cycle.
All right, let's do a super high-yield recap for your exams. Here's what you need to lock in. The HPO axis is an orchestra. The hypothalamus conducts with pulsatile GnRH. Pulsatility is everything. Slow pulses get you FSH, fast pulses get you LH. The absolute game changer is when sustained high estrogen flips the feedback switch from negative to positive. That flip is what causes the LH surge, and the LH surge is the direct trigger for ovulation. After that, progesterone from the corpus luteum preps the uterus. You master that sequence, and you have absolutely mastered the menstrual cycle.
So I'll leave you with one last question to really cement this. We spent a lot of time on negative feedback loops that keep the system stable and in check, right? But which feedback loop is the one that actually unlocks ovulation? The answer, of course, is in that dramatic mid-cycle switch to positive feedback. That's the key.